maternity workshop session 2. We had a great session last week. This session is on improving outcomes in pregnancy, preterm birth, growth, restriction, and family violence. I'd like to start by doing the acknowledgement of country. So Northwest Melbourne Primary Healthcare Network and the four shared maternity care collaborative hospitals would like to acknowledge the traditional custodians of the land on which our work takes place. The Wurundjeri Wurrung people, the Boon Wurrung people, and the Wan Wurrung people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping. So this is a Zoom webinar, so all attendees are muted. If you have any questions, don't use the chat. Please use the question answer box. If it's a straightforward answerable, type a reply so everyone can see it. Otherwise, we'll ask the speakers and we're at the end of all the presentations. The presentation is being recorded and we will be sending everyone a link with the slides at the end of the presentation. Just make sure that you've all registered with the same name as your event registration so we can mark you all off as attending. If you're not sure how to change it or you just want to confirm, please type it into the chat and the lovely people from the Northwest Primary Healthcare Network will mark you off. So yeah, you can send the messages to the Northwest Primary Health Education if you've got a different name. Just to acknowledge the people who've worked behind the scenes to make this happen. So we've got a number of people from the Northwest Melbourne PHN, including Yvonne, who's done a lovely job facilitating this. I represent Northern Health. We've got Mercy Health, Western Health, and the Women's Hospital as part of the collaborative. This is the contact details. So this will be sent with the slide deck. So we've got everyone's details here, and if you've got any questions, you can let your hospital know. Just in terms of the presentation, so we've got a couple of topics from the different speakers who I'll introduce on the next slide. Let's go. Oh, actually, I want to talk about health pathways first. So this is something we talked about last week, and I just want to start off with the people who are here right now. We had a couple of questions asking about if you're out of the region, the Northwest Primary Healthcare region, how do you access health pathways? So we reached out to the team and all the people who are part of the Shared Maternity Care Collaborative and are affiliates can have access. But when you apply, you just have to let them know. We will confirm that you've been registered as part of the collaborative, and then you'll be able to get access to the Northwest PHN, even if you're outside of the region. That is only for people who are shared maternity care affiliates. So just in terms of what they are, I know we've covered this last week, but I'll just go through it again. I use this almost daily in practice. It is a very good website, similar to ETG with local guidelines and pathways. And just advises on the most appropriate hospital, health service, allied health, and sort of has sort of standardized criteria on what you should be referring to hospital. It has an extensive section of women's health, obstetrics, and antenatal care. And when you log into the Melbourne one, this is sort of what you can see. You can bring them all up on the side. So if you just want to go browsing, and just as an example, if you look up sort of antenatal care first attendance, I use this actually quite often because I'm often printing handouts that this website links to, that Health Pathways links to. But if you're not sure about something, it's a really good resource. So if you forget who needs a higher folic acid supplementation, you can use this and it'll just remind you of where to go. And it does link to local services. So particularly if people don't work in the region or people aren't familiar with the service in the region, we can refer our patients to the best service nearby. So again, just more examples. All of the little blue links open a submenu, so it's kind of quite neat. So what I was talking about before with the antenatal consults and the folic acid, you can click on that. It'll just tell you the group of women who we're targeting with the 5 milligrams per day antenatal supplements. So it tells you the statewide referral criteria. And it does that for not just antenatal women's health, but also a number of other medical conditions as well, including a lot of hematological ones. So I do use this resource all the time. And yeah, when you jump in, you can have a play around. You can register for CPD. So if you do spend a bit of time on the website, and it will tell you also how to make your referrals to the different hospitals. Um, so yeah, if you're having trouble, you can access the referral forms and contact details there too. We do have specific guidelines on family violence, which is one of our topics tonight. And then you can get a sort of list of contact numbers for sort of high risk, immediate support, but also lower risk resources. And this can often link to websites for patients and sometimes handouts as well, which you can print for patients. Cool. And then just on the other side, just again, some more resources, and they are based on region. So you can access the region for East Melbourne, Northwest, and also statewide. Other relevant pathways, this is going to be sent in the slide deck. And so I wanted to link to it and just to bring people's attention to the ones we've already got available. So we talked about CPD. So this is kind of new, and I'm yet to register for this part, but I should because I spent quite a bit of time on health pathways. But you can register for CPD points and getting a CPD report at the end of the year by basically clicking on the side there as it says, and then adding learning notes and then creating a report for your CPD learning. It'll track the hours, and then you can use that as evidence for your CPD home. Cool. And so this is how you can sign in and register. A quick Google of Health Pathways Melbourne will take you to this website. Now, remember, you have to add Melbourne to get to this Northwest PHN one, because otherwise you'll probably automatically get linked through Google to your local one. So, and any questions, you can email them here. We've been in touch with them about the shared maternity care affiliates and getting them access. So we're very happy to offer that. Cool. Cool. And just a note on OzCaps. So they wanted us to share this slide. It is a free online resource available for clinicians just regarding long-acting reversible contraception and early medical abortion services. It has a number of resources for providers and access to things you can print out for patients. It's got a number of project partners, and you can get evidence-based sort of resources, guidelines, printouts, as well as education and training. So if you want to join, it is free to join, and you can access a number of different resources here too. Cool. I would like to very warmly welcome the speakers. I'm going to introduce them all at the beginning, and then we're going to start in this order and then we'll bring them on. But first off, we've got Dr. Bethany Sampson. She's a generalist obstetrician and gynecologist working full-time for Western Health. She's currently the clinical lead for maternity and gynecology for the Bacchus Marsh Hospital, which provides low-risk obstetrics and gynecology to outer Western Melbourne. This role spans the full continuum of women's health from antenatal care and childbirth to postnatal support, gynecology, clinics, abortion care, and surgical services. Next up, we've got Professor Fabricio Costa. He's a consultant in maternal fetal medicine at Gold Coast University Hospital and Professor of Obstetrics and Gynecology at Griffith University. His research spans early pregnancy screening, preeclampsia prevention, and fetal DNA testing. He leads national efforts to implement a clinical decision tool in Australia and has published over 220 peer-reviewed papers. His work integrates lab research, clinical trials, and health policy to improve perinatal outcomes. And last but not least, we've got Dr. Tanya Alice, who is a qualified clinical social worker with additional credentials in management, leadership, and workplace training. She has extensive experience across health, government, and community sectors, including roles as training officer, team leader, and program manager. Her work focuses on supporting vulnerable individuals and families facing complex medical and social challenges. Tanya has a strong interest in family violence practice and is passionate about trauma-informed care for both children and adults. Cool. So without further ado, I'd like to welcome Bethany to give us a talk on fetal growth restriction. Bethany, you can share your slides and I will stop sharing. Thank you.
Sorry, I feel like it always takes so long to wind up sharing your slides when you get started. So I'm giving a talk today on fetal growth restriction. As Richard said, I'm a generalist obstetrician and gynecologist. I've done my very best to try to make this talk as sort of broad as possible, also trying to focus a little bit on primary health care. One of the frustrating things I think with fetal growth restriction is that a lot of places do things slightly different. So some of the things that are done at Western Health may not match what's done at other places, but hopefully things will work well for everybody within this talk. So we're just going to start by defining fetal growth restriction. So in particular, just distinguishing the difference between SGA and IUGR or growth restriction. So small for gestational age is a very sort of umbrella term. We're talking about any baby that's born below the 10th centile for their gestation. It is really important to know that not all babies who are small for gestational age or SGA are actually growth restricted. And we certainly do see some babies that are not defined as SGA, so they're above the 10th centile who are growth restricted. Annoyingly, 10th centile cutoffs don't take into consideration genetic considerations for fetal size, particularly when we're thinking about parental height and weight, ethnicity, parity, and fetal sex. And babies that are constitutionally small, so babies that are sort of more genetically small, are less likely to be an increased risk of perinatal mortality or morbidity. We can help to sort of distinguish a little bit between the babies that are going to be SGA versus growth restricted by using individualized growth charts. And without them, it can be quite challenging to distinguish the two. But there are a couple of things that we'll talk about that help with that. And more than 50% of babies below the 10th centile will just be constitutionally small. So then moving on to fetal growth restriction or intrauterine growth restriction. This is where we have a pathological process where a fetus does not reach its growth potential. We can see this in babies where we see a reduction in growth centiles throughout the pregnancy. A fairly easy cutoff would be a fall of more than 50 centiles for abdominal circumference or estimated fetal weight in between scans, or when we're crossing quartiles on growth scans. Anybody with a reduced abdominal circumference on ultrasound compared to the head circumference, and sometimes that can be quite subtle, sometimes that can be very obvious. Change in Doppler studies demonstrating increased placental blood flow restriction. We'll talk about that a little bit more later on, as well as reduced amniotic fluid on ultrasound. It's also good to know that a baby that's got severe SGA, and the definitions might change depending on the health service for that. So some places will use 5th centile, some places will use 3rd centile, but quite generally 3rd centile is a very acceptable cutoff for severe SGA. They're very unlikely to be SGA and more likely to be a growth restricted baby. I just popped up this slide. This is just an example of estimated fetal weight, and you could sort of imagine, I don't know if my mouse actually works on this, but crossing quartiles is in if you had a baby, say at 28 weeks here, that was sitting sort of on the 80th centile, perhaps that might cross down to the 40th over several weeks. That's when we're talking about crossing quartiles. So why do we really care about fetal growth restriction? So there's several things that it can affect in a person's life. So antenatally, we do know that fetal growth restricted babies have an increased risk of stillbirth. There's also an increased risk of preterm birth as well as cesarean section. In the neonatal period for these babies, they're more likely to have feeding difficulties, jaundice, late onset sepsis, and hypoglycemia, or just difficulty managing their blood sugars. Bronchopulmonary dysplasia, neck and pulmonary hypertension can also be seen, and these are sort of things that we might see in the preterm babies as well. Long term for these children, they're more likely to have neurodevelopmental delays and ADHD, as well as asthma, childhood and adult obesity, as well as metabolic disorders, so hypertension, cardiovascular disease, and type 2 diabetes. We often break down our different types of growth restriction, and there's two sort of very main categories that we can use for this. So this is early onset versus late onset. So early onset is any baby with growth restriction before 32 weeks. These are your very high risk patients. These are going to warrant a fetal medicine referral. They will need tertiary care. The facility will need to have high level neonatal care. And the frequency of scans will be individualized, but it can depend on the Doppler findings. And this is when we see growth restriction related to more commonly preeclampsia, infection, chromosomal abnormalities. And then late onset is when we see this after 32 weeks. So these are still very high risk pregnancies, but they don't tend to need to go to the fetal medicine team. They will need obstetric-led care. They will need more frequent growth scans, usually every 2 weeks, as well as Doppler and AFI every week, and CTG monitoring. The frequency of that will also depend on what happens in the pregnancy, as well as local guidelines. This is a really nice table that I believe it's come from the ISUOG guideline. This just outlines some of the differences between the early onset and late onset FGR. So when they're talking about the main clinical challenge with early onset FGR being management, it's really about timing of delivery. So with these sub 32-week babies, balancing the difference between trying to gain maturity versus that risk of stillbirth that we see with growth restricted babies can be quite a significant challenge. This is going to make up about 30% of our growth restricted babies. We tend to see very small babies at this gestation. So these are often the ones below the 5th or 3rd centile. The Doppler can have a sort of a range of Doppler abnormalities, including the umbilical artery, the middle cerebral artery, and the ductus venosus is something that we look at in terms of delivery timing for these. And I'll talk about Doppler again later on. Biophysical profiles are often abnormal. This is often associated with hypertensive disorders of pregnancy, such as preeclampsia. And when we look at placentas, we see poor placental implantation, spiral artery abnormalities, maternal vascular malperfusion. The late onset growth restricted babies, they can be a little bit more challenging to detect. So we're talking about over 32 weeks, making up 70% of growth restricted babies. Sometimes it can be very subtle on ultrasound and not always well seen, especially because these babies are not always really, really small. Sometimes they're around the 10th centile or even a normal size, as I'd mentioned earlier. We often worry about their cerebral blood flow redistribution, which again, I will talk about a little bit later. And they're less likely to have hypertensive disorders of pregnancy, though they certainly can. And the placental findings tend to be a little bit more non-specific. So I've just put together a little case just to help sort of talk through all the points throughout this. And I've chosen Isabel as a case for this. So if you imagine Isabel as a client of your practice, a 23-year-old female in her first pregnancy, she's married to Jeremiah, their childhood sweethearts. She doesn't have any medical history. She has a normal BMI. She's a non-smoker, is not taking any drugs or alcohol. She's very diligent. She's had negative carrier screening done before pregnancy. She's been taking a pregnancy multivitamin. She's come to see you nice and early. She's had booking bloods that have been done, a normal NIPT, a dating scan has been completed, along with an early anatomy scan. And she's been referred to a local health service at 14 weeks, identified as being a low-risk pathway, and she's asked for shared care to be done through GP practice. So Isabel is a really nice example of somebody with very minimal risk factors for growth restriction in pregnancy, and she's sort of the ideal patient that we love to see. So when we think about the risk factors of growth restriction in pregnancy, there's quite a lot. This table is from the RCOG guidelines, and it does break down everything in bold being what they consider to be a major risk factor, and the ones not in bold to be just a risk factor in general. So age greater than 40 years being a major risk factor, it's quite significant compared to over 35 years, first-time pregnancies. BMI can be a risk factor for growth restriction, but BMI also in and of itself can just complicate your diagnosis of patients with growth restriction because it can be a little bit harder to tell if a baby is palping small, if the woman is larger. Smoking is dose dependent. So somebody smoking 1 to 10 cigarettes per day certainly does have an increased risk of growth restriction compared to the general population, but over 10 cigarettes per day, the risk goes up quite significantly. And anybody doing significant amounts of cocaine is also at a high risk. I did find it interesting that daily vigorous exercise is in this guideline. I think that there's some mixed findings about exercise in pregnancy, and it probably is more relating to women that are not doing as vigorous exercise early in pregnancy. And I very rarely look at people's fruit intake pre-pregnancy, but that is also mentioned there. There's some really, really obvious key ones here. So somebody that's previously had an SGA baby or a previous stillbirth is a very major risk factor. The development of preeclampsia or previous preeclampsia, people that have a short pregnancy interval or a very long pregnancy interval, And then interestingly, maternal or paternal SGA are both major risk factors for SGA. And that's probably thinking about people that had a genetic predisposition to having a healthy but small baby. And then some maternal medical diseases, so hypertension, diabetes, renal diseases, and antiphospholipid syndrome. During the pregnancy, there can be some things that will develop that will make us be more prone to look for people to have growth restriction and increase our monitoring. So heavy bleeding in the first trimester or a threatened miscarriage, echogenic bowel, preeclampsia is a quite an obvious cause of growth restriction to us. Or gestational hypertension, having an abruption, APHs during pregnancy, so antepartum hemorrhage, or weight gain, high caffeine intake, or low PAP-A in that first trimester. So Isabella comes back to see you at 20 weeks for her morphology scan, and the result is looking normal. The placenta's anterior and clear, and the baby's growing well on the 60th centile. The pregnancy continues to progress well, and she's attending regularly. She's seen the local health service at 28 weeks and plans to see them again at 36 weeks. You have an appointment together at 34 weeks, and at this point you do notice that the fundal height has not changed over the last 2 appointments. So when you saw her at 24 weeks, it was measuring 24 centimetres. At 28 weeks, it was 28 centimetres. At 31 weeks, it was 31 centimetres. And then at 34 weeks, it was once again 31 centimetres. So what to do in this situation, which is something that we do find ourselves seeing sometimes in these nice low-risk pregnancies, just a fundal height that's not growing, but also that's 3 centimetres below dates. So the right thing to do is to refer her urgently to the local health service for review, usually on that same day. She has a CTG there, and that is normal. She has an urgent AFI and Doppler, and that's also normal. She has a growth scan organised within the next couple of days, which shows the estimated fetal weight is on the 40th centile, abdominal circumference is on the 20th centile, a normal AFI and Doppler. She's then seen by an obstetrician who repeats the fundal height at 35 weeks and feels that it's actually 35 centimetres. They're quite happy with how things are going, but they do recommend that she has the growth scan repeated again at 36 weeks and continues to see you until 38 weeks when they'd like to see her again. So thinking about monitoring pregnancies for fetal growth restriction. So all pregnancies at their booking in visit should have their growth restriction risk outlined, either by the midwife or an obstetrician. This includes confirming the estimated date of delivery. So it's really important that we have really good and accurate dates, because without accurate dates, it can be really hard to know how accurate our growth scans are going to be. Looking for those pre-existing risk factors such as smoking, maternal weight, looking at previous pregnancy outcomes, reviewing any investigations to date that could be abnormal, and then just thinking about what antenatal screening is going to be indicated for that patient. So whether they're just going to be somebody like Veli that's just going to have fundal heights done versus somebody that might have increased ultrasounds. And that's going to depend on local guidelines as to how frequently they're done, but typically that would be scans being done between 28 and 36 weeks. So fundal height measurements are something that we routinely do on all patients during a pregnancy. So a fundal height is measurement in centimetres of the distance between the symphysis pubis to the uterine fundus. We start doing this at 24 weeks. Very important when you're doing fundal height measurements to make sure that the tape measure is facing away, because otherwise you're just very prone to cheating. We all do it. I caught myself doing it actually last Friday in my antenatal clinic, that I rechecked a fundal height because I was looking at it and changed it by a couple of centimetres. If you're ever just wondering what it should be, very easy. The fundal height should match the gestation. So at 34 centimetres, if you've got a fundal height, at 34 weeks, if you've got a fundal height of 34 centimetres, that's likely to be normal. It should trigger warnings to you if the fundal height is less than or equal to 3 centimetres away from the dates, and that should warrant further investigation for growth restriction. Conversely, if they've also got a fundal height of greater than 3 centimetres, then you need to think about whether they could have a large for gestational age baby or even polyhydramnios. Also think about it at times when you notice the fundal height's becoming static. So say you've seen someone at 34 weeks and it was 35 centimetres, you see them again at 36 weeks and it's still 35 centimetres, that fundal height is not increased normally, and that should warrant thinking about some further investigations. So static or reduced fundal height should trigger a review for CTG and an urgent ultrasound to look for fetal wellbeing and growth. So you then see Isabel as planned at 36 weeks. And she's had her growth scan repeated at 36 weeks, and now the estimated fetal weight is on the 20th centile with an AC on the 15th centile and normal AFI and Doppler. The fundal height again at this appointment is 33 centimetres. So if we think back to when she saw the obstetrician and they thought that it was 35 centimeters. I think that I've just put this in here as a really sort of key moment to remember to really trust your instincts about the patients that you know very well. If you're noticing that the fundal height is not increasing and you've had really nice continuity with a patient, you're much more likely to be correct than the person that's met her once. You can also see on this growth scan that at the morph scan, the baby was on the 60th centile, and then at 34 weeks, the baby was on the 40th centile. We're now on the 20th centile. So over time, this centile has reduced. There's a slight discrepancy with the abdominal circumference being that little bit behind. But thankfully, the AFI and Doppler are normal. So this is the sort of patient where you should be really thinking, yes, the estimate of fetal weight is normal. It's above the 10th centile, but it's dropping. The fundal height is dropping. She needs further investigations. So she is then referred back to the local health service with a big accentuation in your letters noting the drop in centiles as well as the reduced fundal height. And this obstetrician that sees her very much agrees with your assessment and plans for some weekly monitoring and induction of labour at 38 to 39 weeks. So very important just to know some things about the limitations of monitoring. So a symphysis fundal height has a very poor sensitivity, so it's only around 27%. There's lots of things that are going to impact this. So maternal BMI can certainly impact. So if a woman is bigger, the fundal height is much more likely to be large. If they've got a fibroid uterus, that's going to falsely increase the fundal height of the uterus. User variation. So a medical student versus an experienced obstetrician are likely to get very different fundal heights, but that reliability of user variation is definitely improved with continuity of care. And fetal presentation, so a longitudinal baby versus a transverse baby might have different fundal heights. Ultrasound as well is actually not 100%. So estimated fetal weight can be discordant by up to 500 grams at term. There are several things that can impact upon that. So there is humans that are doing these scans, the skill level, the experience, the environment, even the baby's presentation and the gestation. The woman's BMI can impact upon that as well. So there are many things that can impact on how well we're able to get a fundal estimated fetal weight. Ultrasound also comes at a cost. So if we're getting private ultrasounds, that can be very expensive for some women and they're not able to afford it. We particularly see that with our non-Medicare funded patients, that a lot of them do not want to have ultrasounds because they're just unable to afford that. And then the availability within the public sector is getting less and less and less, especially as our birth rate's increasing. So Isabel thankfully has a safe induction of labour at 38 and 4 weeks, and she delivers a healthy baby girl who she named Susanna. Susanna is born on the 15th centile for her gestation. She's a well baby, though does have some challenges with establishing breastfeeding, which is resolved with support of the local lactation consultants. So at 3 months postpartum, if Isabel is asking about her pregnancy, she wonders if there's anything that should be managed differently in a future pregnancy or any steps to take in the interim. So again, despite the fact that Susanna was born at a good weight, at a normal centile for her gestation, with everything that has happened here, I think it's quite clear that this is an example of a baby that was a normal size, but quite likely growth restricted. She didn't quite reach her growth potential. So thinking about preventive measurements for, preventing measures for growth restriction. There is disappointingly limited things that we can do to prevent it. We don't have at the moment some magic pill that we can give that's going to change things, but there's certainly some things that we can look at doing. So pre-pregnancy, reduction or quitting of smoking can certainly improve outcomes, normalization of weight, just in general, making sure that women have good nutrition, regular exercise and stress management, and just supporting that interpregnancy interval of at least 6 months in between conception. So allowing women access to good contraception can be vital here. Antenatally, there may be for some people some benefit for aspirin. In Belly's case, that would not be beneficial because this is really only beneficial for women with a history of early onset preeclampsia. So aspirin reduces the need for delivery for early onset preeclampsia. Smoking cessation or reduction in pregnancy can still be beneficial, especially if they can get it down to under that 10 cigarettes per day. Encouraging people to have really good engagement in healthcare in particular. This is just going to help us to identify women with growth restriction and manage them well. And continuity of care models are more likely to identify growth restriction earlier. So trying our best to implement continuity of care is really important. So we see continuity of care with GP shared care, as well as with midwifery group practice and in private care. And hopefully at one point in the future, we'll see it in other parts of maternity health care. So there's several things that can cause growth restriction. By far, the most common thing that we see is a placental cause of growth restriction. So there are things that can essentially just reduce the ability of the placenta to provide nutrients to the baby. So substance abuse, smoking cocaine and alcohol can all directly damage placenta and placental blood flow. Medical conditions such as hypertension, preeclampsia, diabetes, autoimmune diseases, thrombophilias, and renal disease can all affect the placenta. Abnormal placentations, so if you've got somebody with placental adhesive disorders, so placenta accreta, for example, someone's had a placental abruption or placental infarcts, that's going to reduce the surface area of the placenta that's available for nutrient crossover for the baby. Umbilical cord abnormalities, so see the velamentous cord, marginal cord insertions, or a single umbilical artery, and multiple gestations for twins or triplets. Non-placental, so there are infections that can increase your risk of growth restriction. This is our torch infections, so HIV, CMV, malaria, rubella, syphilis, toxo, TB, and varicella can all do this. Chromosomal abnormalities, major congenital abnormalities can also cause growth restriction, as well as there can be metabolic disorders causing it. So Belly then comes back to see you 4 years later. Things have changed a lot for Belly in this time, but she is pregnant now and she's unsure of how far along she is. She has separated from Jeremiah, she's moved to France, and she's taken up smoking 20 cigarettes per day. The separation has placed some significant financial strain on her family and on her. You organise an urgent dating scan for her, routine bloods, and discover that she's actually already 16 weeks pregnant. All of her bloods have returned normal. You place an urgent referral into the hospital for booking in, as well as organise her morphology scan, just knowing that at 16 weeks, she may not be able to get that from the hospital in time. And she's decided that she doesn't want to pay for any aneuploidal screening this time with the change of their financial situation. She's booked in at the hospital again and recommended for shared care again. So she's gone in and told the hospital that she's going to quit smoking. And they've looked at her last pregnancy notes and they noted the baby was above the 10th centile. And as a result, they've not flagged her as an increased risk for SGA. And she's actually not yet quit smoking. She's had a morphology scan, which shows a normal fetus. The baby's on the 60th centile, but has a marginal cord insertion. And at the booking appointment, this result was also not yet back. So knowing that despite the fact the baby was above the 10th centile, it was quite likely a growth-restricted baby, as well as with the new risk factors that have developed for her, including ongoing smoking, as well as having a marginal cord insertion, she is a high risk for growth restriction in this pregnancy. So the correct pathway here is actually just to send her back to the hospital. So I would recommend Isabel to be having hospital-based maternity care due to multiple risk factors for FGR and ask her to be seen at about 24 weeks for a management plan for the pregnancy. The hospital see her and they do correct her pathway. And if she was being seen at Western Health, we would recommend her for growth scans at 32 and 36 weeks for smoking as well as the marginal cord insertion. So I'm going to move on to talk about some of the investigations that we use for fetal growth restriction. So this is both for babies that are already growth restricted, as well as when we're thinking about monitoring for growth restriction. So ultrasound, we can use this to estimate fetal weight, as well as markers of fetal well-being. And it is really important to remember that the ultrasound is just an estimation of the fetal weight. It's not a true value necessarily. So we estimate it using a combination of the measurements of the baby's biparietal diameter, the head circumference, the abdominal circumference, and the femur length. And the accuracy can be limited by multiple things that I've discussed previously. We can improve the reliability for ultrasound by looking at it over multiple scans over several weeks. So if you've had sort of 2, 3, or even more scans, and you look at the growth of the baby over that time, and comparing that to growth charts, you're going to have a better idea of how well a baby is growing than if you just have one scan, say at 36 weeks. Ideally, we don't want to be performing growth scans more frequently than every 10 days, but most of the time we'd actually put it at every fortnight. So the distance in the times is just trying to limit the human error factor and be able to sort of look at it more over time. When we do ultrasounds, we also look at Doppler studies, and you'll see on most growth scans that they will report if the Doppler were normal or not. There's three main Doppler that we're looking at with growth restriction. The bottom one, ductus venosus Doppler, are not always done. But an umbilical artery Doppler is looking at the blood through the umbilical artery. We see an increased umbilical artery Doppler when we have placental insufficiency and maternal malperfusion of the placenta. A progressive increase does correspond with reduced placental surface area and therefore a loss of gas and nutrient exchange. And sometimes we might even see absent or reversed end diastolic flow when we are looking at the umbilical artery Doppler. So I like to think about the umbilical artery Doppler as it's really representative of placental function, and the placenta is supposed to be a very, very gentle blood flow. It's supposed to gently pass nutrients from mother to baby. If there's something that's stopping that from happening, it's going to work harder and it's going to increase its blood flow. It's going to increase its values on the umbilical artery Doppler. That's just how I think about it in my brain. If I'm ever worried about a low umbilical artery Doppler, I think, no, that's lovely. That is a nice, gentle exchange of gas between mother and baby. The MCA Doppler is the middle cerebral artery Doppler, so Doppler in the baby's brain. And in a normal fetus, we see an MCA as being a fairly narrow vessel, which is going to have a higher flow. So you're thinking of sort of your skinny glass that's going to be taller. If we have significant growth restriction and the baby is becoming hypoxic, then you might see vasodilation of that blood vessel, and that's going to drop the MCA Doppler. So as a response to that hypoxia, you might see a reduced MCA PI. You might also see this described in a growth scan as being cerebral redistribution. The ductus venosus Doppler is actually not something that I am particularly good at doing or know how to do. This is very sort of an MFM territory Doppler, but essentially it's looking at the cardiac function of the baby. So a normal ductus venosus demonstrates an A wave, and when we see cardiac compromise as a result to severe growth restriction, you get an absent or reversed A wave in response to that. The other part of ultrasound that can be done is a biophysical profile, and this is not necessarily done that regularly, but a lot of guidelines do talk about it. So it gives a score out of 8, and the options for these 4 things are either a score of 0 or 2, so for fetal breathing, tone, movement, or amniotic fluid volume. And if you have a score of less than 2, that's 100% sensitivity for fetal acidemia, but a score of less than 4 is a higher likelihood of fetal acidemia. This is a really nice flowchart of how we use Doppler in terms of delivery for women with growth restriction. And this has come from the issue of guidelines, I'm pretty sure. Essentially, when we've got our pre-26-week growth restricted babies, management is always going to be personalized. These are really, really complex babies. They may be too small despite being at a viable gestation to be compatible with life. And so that's very much an MFM patient neonatology management plan. Below 32 weeks, we're often really relying on the ductus venosus to indicate when we're going to be delivering or abnormalities in the CTG. From 32 to 36 weeks, we look at the reversed or absent end diastolic flow in the umbilical artery as being an indicator for delivery, or again, abnormalities in the CTG. And then over 36 weeks, we're going to have a slightly lower threshold. So if we're getting some abnormalities, so an increased umbilical artery PI, we're more likely to deliver, or a very small baby. And then over 38 weeks, we're looking at signs of cerebral redistribution on top of this, potentially being a reason to deliver. In terms of further investigations for our growth-restricted babies, so CTG monitoring is very helpful. It gives real-time insight into fetal well-being. So if we've got a CTG that's showing accelerations in normal variability, we're very unlikely to have a hypoxic fetus, especially in that moment. Local guidelines for the frequency of CTG monitoring could vary. Typically, we wouldn't do them prior to 28 weeks. In my hospital for a baby with normal Doppler, but that's small, we would do them every week. And there are potentially other indications where a CTG may be indicated over 28 weeks that can also be associated with growth restrictions, such as APH, hypertension, or even intrapartum. It's just good to remember. Other investigations, so there are some special times we might do additional things. So if we're seeing growth restriction prior to 24 weeks, that's going to have a much higher association with chromosomal abnormalities. In people with growth restriction and polyhydramnios, we should also be considering infection, though it's very easy to do a torch screen on anybody, but especially if we're seeing polyhydramnios, so increased fluid volume on the scan, we want to think about that. At all gestations, but especially the early onset before 32 weeks, we want to also think about preeclampsia. So it's very reasonable in those patients to do a preeclampsia screen, even if the patient is normotensive. So Belly, coming back to her, she's continued her care with the pregnancy at the hospital. She's had a growth scan at 32 weeks that shows baby's growing really nicely on the 60th centile with an AC on the 55th centile, normal AFI and Doppler. But then at her 36-week scan, there's a significant drop in the growth. So the growth drops down to the 15th centile. The abdominal circumference is on the 8th centile with normal AFI and Doppler. And at this point, we can very clearly identify a growth restriction for her. She gets recommended for weekly AFI and Doppler and a CTG and has an induction of labour booked at 38 weeks because she also develops some reduced movements. She delivers a boy who she names Conrad. He's on the 9th centile. He's born fairly well, but he does have a brief period in a special care nursery with some TTN, but then goes home with her and is feeding well. Thank you.
Thank you for that, Bethany. That was very insightful, and I really appreciate the use of the case. I wrote down plenty of notes, so lots to think about. I'd like to introduce our next speaker, who is going to present on a similar but slightly different topic. So we've got Professor Fabricio Costa. He's here to talk about preterm birth and preeclampsia in early pregnancy. Thank you, Professor.
Thanks so much, Richard. Thanks so much for the invitation. Just share my slides here. I hope that you can see them. Probably I know some of you. I worked in Melbourne before moving to Queensland for 10 years at Women's Hospital and Monash Medical Center. I really missed a lot of aspects from Melbourne, but I can tell you I'm not missing the weather. But let's talk about prediction prevention of preeclampsia. That definitely is my passion for the last 25 years. I think that we still have a problem.
Sorry,
it doesn't matter.
Yeah, the slides aren't up yet.
They're not yet?
Yeah.
Just let me try to share again. Okay. How about now?
Yes.
Yep, we can see them. Thank you.
Great. I'll just come back here. Sorry about that. Okay. Let's talk about prediction prevention of preeclampsia. Doesn't matter how hard we are working, we just cannot decrease the rate of preeclampsia, preterm birth, and stillbirth. If you look at the graph in the left-right side, there's a work that we published with MARAM population over 6 years from 2017. This purple line is preterm preeclampsia. You can see that's completely flat line. This purple line is early preeclampsia. And also there's no decrease, completely flat. It means that we are doing at this point in time, unfortunately, it is not working. And we have to change our tactics. And I'm going to show you how you can do it. Basically, the current guidelines that we are using in the UK, from NICE, ACOG in the US, Soman's guideline in Australia and New Zealand. Basically, you are using risk factors. If someone has at least one high risk factors, and you can see that they are very common ones, and they are very similar between the different guidelines, or has at least 2 moderate high risk factors, is deemed to be high risk for preterm preeclampsia. Very easy to apply. These risk factors, they are real. However, the detection rate is only 40% with 10% false positive rates. It's better to flip a coin than to use this kind of guidelines. This is the main reason that we are unable to decrease the rate of preterm preeclampsia at this point in time. However, with ultrasound and first trimester screening, we have a great opportunity. I think that most of us, we are very used with this kind of antenatal care. Patients are going to you guys, GPs, in early pregnancy. You are requesting first trimester screening, but the patient is reaching the hospitals over 16 weeks and sometimes over 20 weeks after the morphology scan. However, more than 80% of the Australian population is having first trimester screening between 11 to 13 weeks plus 6. And this started for Down syndrome, but actually we can use this point in time as a major window for screening of pregnancy complications. And then I can offer personalized care instead of population care when I'm using the history-based risk factors. We did that before extremely successfully, right? We did that before with Down syndrome. I have 30 years after my graduation in medicine. When I was at med school and doing my training obstetrics and gynecology, we are offering amniocentesis to try to detect Down syndrome for everybody over 35 years of age. And this was a terrible thing, because offering an invasive test, besides the low risk of miscarriage, this risk was real, and the detection rate was only 30% if I'm using maternal age. From 2000, we started in Australia a very successful program. That's the first trimester combined screening that I'm using, of course, maternal age, but I'm using the nucleotranslucence that I can measure by ultrasound, beta-HCG, and PAPA. And then the detection rate for Down syndrome went to 90% with 5% false positive rates. This is a very, very successful story. And then more data from Victoria Dissahui, that's the MFM from Mercy and Northern. She's leading this project. And this is a major impact that first trimester screen caused. In green is the number of amniocentesis offered, and in purple is the number of CVSs. If you look at here in 2000, when the first trimester screening started in Australia, was the peak of offering of invasive procedures. You can see that doing first trimester combined screening, because the detection rate is so high, we're able to decrease quite a lot the number of invasive procedures, and then we are in around 2% of the cases, even after the advent of NIPT that we started to offer in early 2013 in Victoria. I was very happy that was part of the initial group that started to offer NIPT in Victoria. If you think that you are doing less invasives, you are making less diagnosis of Down syndrome, it's completely the opposite. You are making much, much more diagnosis of Down syndrome. This is a very successful example, and you can follow this lead for preeclampsia screening. We can use exactly the same rationale than Down syndrome screening to screen for a preterm preeclampsia at the same time, at the time of the nucleotranslucence scan between 11 weeks and 13 weeks plus 6 days. Basically, I'm using maternal history. I'm using ultrasound crown to rump length. I'm measuring patient height and weight. I'm calculating BMI. And then I'm asking very, very simple maternal history questions that you can see here. The same institution that used screening the fetal medicine from the UK was the one that was used algorithm to predict preeclampsia. If I'm using free beta-HCG and PAPA for Down syndrome screening, for preeclampsia, beyond CRL and maternal history, I'm using mean arterial blood pressure. Very, very simple to do that. I'm using an automated validated device. I'm measuring the blood pressure at the same time than ultrasound. In my center, for example, we trained our sonographers to do so. You can train your midwives. You can train even your secretary to measure the blood pressure. Using the automated devices, you're measuring the blood pressure simultaneously, twice in each arm. You're putting this information in the software is calculating the mean arterial blood pressure. At the time of the nuchal translucency scan, our colleagues, radiologists, or ourselves, MFM sonographers or COGUs, can measure the uterine artery pulsatility index in the right side, in the left side, and then you're putting the information in the software, is calculating the mean pulsatility index. The best blood biomarker for the prediction of preeclampsia is PLGF, that's placental growth factor. That's far superior than PAPE. PAPE actually has been dropped in the last version of the Fetal Medicine Foundation software. Besides, PAPE is not Medicare rebatable at this point in time. I was able to introduce PLGF for the whole state of Queensland a couple of years ago, and every patient that's having a public appointment in any Queensland Health hospital can have access to PLGF. It means that this is very possible. Like the Down syndrome screening, you're using a cutoff. The best cutoff for preeclampsia screening is when the risk is higher than 1 in 100. And then what we do, for this high-risk population, we prescribe from that time, at the time of the screening, aspirin, 150 milligrams every night. Nighttime is the best time to take it. From that stage of the screening, up to 36 weeks of pregnancy, and then you're stopping at 36 weeks. I'm going to show you this high-risk population for preterm preeclampsia is also high risk for fetal growth restriction. Then you are suggesting for this high-risk group a growth scan at 28 weeks to pick up early onset fetal growth restriction, and another growth scan at 36 weeks to pick up late onset fetal growth restriction. If someone is high risk for preterm preeclampsia but didn't develop preeclampsia, you are suggesting delivery at 39 weeks because you can decrease the rate of term preeclampsia doing that in around 30% as well. And doing this screening, papers that they started in 2009, and along the time, they're published in every single continent. There's external validation everywhere, including in Australia since 2013. You can see for preterm preeclampsia, I can double the detection rate from 41% using maternal history to 82%. For early preeclampsia with delivery before 34 weeks, we also can double the detection rate using combined screening from 47 to 90%. Unfortunately, for term preeclampsia with delivery after 37 weeks, the detection rate with the combined screening is better, but it's not very high, it's 44%. We have to use a different strategy that this is growing at this point in time, that's screening for term preeclampsia at 36 weeks. The beauty of this algorithm that you can see, I can use different combinations of these factors. It means that, let's say in Victoria, you don't have PLGF available. But of course, I'm using maternal history, blood pressure is very easy to measure. To do uterine artery Doppler is very easy, but then I can use PAPE. My detection rate goes to 54% if I don't have uterine artery Doppler, goes to 77% if I don't have PLGF, but I have uterine artery Doppler. It means that you can use different combinations, minimum using maternal history and mean arterial blood pressure. We really can improve the detection rate when I compare only with history. But something more importantly, we are telling that you are doing screening for preterm preeclampsia, but actually we are doing screening for all the phenotypes related with placental dysfunction. If someone is deemed to be quite high risk for preterm preeclampsia, if the risk is higher than 1 in 50, the positive predictive value for these complications you can see is very high. For stillbirth, it's 2%. For preterm birth, it's 12%. This is associated with placental dysfunction as well. Hypertension disease in pregnancy, including, but it's not just preeclampsia, gestational hypertension as well, goes to nearly 25%. SGA below the 10th percentile, it's 26%, and CAPO is composites adverse perinatal outcome, happens in 45% of the cases. It means that this is really a truly high-risk population for placental dysfunction that you need to provide more care. However, screen positive rates, if I'm doing this test, is around 11 to 13%. This is the numbers that we got in Australia. If I'm doing only maternal history-based screening, in tertiary hospitals, and my hospital is one example, you are identified as high risk over 30% of our population, and actually it doesn't work in terms of prevention. It means that this is another big advantage of doing combined screening. I can reduce the screen positive rates for this truly high risk group. I mentioned before, this screening was validated in every single continent. This was extensively validated and implemented in Australia. What we have to work is for whole country implementation, and we are doing some work about that. The last continent that validation is happening, and it's happening as we speak. I'm going to Ghana in November because I was invited by the Concept Foundation that's running a major validation study in Africa that's conducted by another Melbourneian. It's Josh Vogel from the Burnet Institute in Melbourne. He's the lead researcher for this study in Africa. And in November, we are going to have a steering committee meeting for this important study in Ghana. Africa will be the last continent that you are making the validation. If you can do preeclampsia screening in Africa, I'm sure that you can do preeclampsia screening in every single place, including regional and rural Australia. But if someone's deemed to be high risk, what you can do to prevent preeclampsia? And there's a major randomized clinical trial that was published in 2017 that's called ASPRI trial. The first author of the ASPRI trial is Associate Professor Daniel Ronick. Daniel works at Monash Medical Center, and I was lucky enough to attract Daniel come to work as my fellow back in 2017, exactly the year that this paper was published, and he stays and he's working at Monash Medical Center. He published together with the Fetal Medicine Foundation group this major study. In 7 countries in Europe, they did first trimester combined screening for 30,000 women. The ones deemed to be high risk, you have 800 randomized for placebo and 800 for 150 milligrams of aspirin. And then you can see the results. Doing so was possible to decrease in around 80% the rate of early preeclampsia with delivery before 34 weeks, and in around 60% the rate of preterm preeclampsia with delivery before 37 weeks, as expected, because probably it's a different mechanism. Term preeclampsia, aspirin is unable to decrease the rates. Term preeclampsia is more likely to be related with maternal cardiovascular issues than placentation issues. After this publication, the major international societies between 2019 to 2021 published the guidelines. ESHOP is the International Society for the Study of Hypertension in Pregnancy. FIGO is the International Federation of Obstetrics and Gynecology. IJOG is the International Society of Ultrasound in Obstetrics and Gynecology. They are supporting this screening. I was lucky enough to be co-author of the FIGO and the IJOG guideline. You can see this picture here from 2019, time that we launched it in Florence, the FIGO guideline, and probably you can see a couple of familiar faces. I'm here in this corner. John Hyatt is a professor of maternal fetal medicine from Sydney that was part of this global working group. Finally, after a long period of time, the pioneer centers, they started to offer first trimester screening for preeclampsia in Australia straight after the local validation in 2013. But the SOMANs in the IJOG guidelines, they are just updated a couple of years ago. Basically, SOMANs and IJOG, and RANSCOG, they are saying exactly the same thing. if the first trimester screening is available, it's the best way to predict preterm preeclampsia. And for the high-risk population, at least 100, but the best dose is 150 milligrams of aspirin is recommended. As I mentioned to you before, I was part of the pioneer group that started preeclampsia prediction as a routine. From Monash, Sydney Ultrasound for Women, and the Prince Alfred Hospital in Sydney. Then, after the very performance of the population, we are able to improve outcomes. You can see here in red the rate of these complications for the population that didn't have the screening. And then in blue, population that were screened and aspirin was prescribed. You can see an improvement in all these outcomes, and I'm going to show you the numbers. For preterm preeclampsia, doing screening in clinical practice, this was outside a research protocol, right? These are patients that they come to our clinics and hospitals, and they had the screening for preeclampsia. We screened between 2013 and 2017 around 30,000 women. We compare with 300,000 Victorian women that didn't have the screening. Doing so, you're able to reduce the rate of preterm preeclampsia in 30%. Preeclampsia overall in 31%. Preterm birth before 32 weeks, 17% reduction. Preterm birth before 37 weeks, 8% reduction. Low birth weight, 11% reduction. It means that in real words, you are really able to improve all these outcomes related to placental dysfunction. But another important part of this algorithm is really true that if someone is high risk for all these placental dysfunction outcomes. But even better, 87% of our population, they're deemed to be low risk, right? If someone is low risk doing first trimester screening, you can see here, it's a truly low risk population. Checking this graph, there's a real division between these outcomes in the high risk population and the low risk population. For this low risk population, I really can assure these women that the chance for them to have preterm preeclampsia and all the other outcomes related to placental dysfunction is quite low, including stillbirth. And then it's a big question. Of course, I'm doing a new test that I have to invest a little bit. I have to do uterine artery Doppler. I have to train my team to measure blood pressure with the automated devices. That's very cheap and easy. And it's preferable to have PLGF. Then is the question if this is cost effective. The two pioneer public hospitals that they started preeclampsia screening in Australia was RPA and John Hunter in New South Wales. My hospital here on the Gold Coast was the third public hospital that started preeclampsia screening. But in New South Wales, they did that for 2 years. And you can see that in 2 years, 6,000 deliveries, they're able to avoid around 30 cases of preterm preeclampsia. In doing so, they're able to save around $1.5 million. Some years ago, we put together an application to Medicare. And then you can see to implement this screening in Australia, we have to invest a little bit less than $7 million per year to pay for uterine artery Doppler and to pay for PLGF. However, the savings is over $11 million per year with net savings of more than $5 million per year if I'm investing in this kind of screening in Australia. We really are waiting for MSAC to change their minds because this initial proposal was denied. And we have so strong evidence that we are hoping to put a new proposal shortly. And we really hope that MSAC this time decides to support preeclampsia screening. I'm as a COGU and working in a major maternal fetal medicine unit, I'm very happy to be able to provide to our patients carry screening for rare genetic conditions. But if you look at the prevalence of these conditions, they are extremely rare. And the Australian government is spending $8 million to do so. And I just cannot see the rationale to support carry screening and not to support preeclampsia screening for all our women in Australia. Recently, the Pioneer Group just published another paper to checking our outcomes and to checking the intervention in terms of preeclampsia. We can see in this graph that's very clear that doing screening and prescribing 150 milligrams is very beneficial. If I'm treating all, if I'm giving aspirin for everybody, there's no benefit. If I'm comparing treating known or the Fetal Medicine Foundation model, that's the line in blue, when the risk is between 1% to 12%, there's a clear benefit of the treatment. There's a clear benefit of the screening and a clear benefit of the treatment. And we proved that for our Australian population many times. The other important thing I mentioned before is PLGF. For the Australian population, PLGF is far superior than PAPA. This is the detection rate using PAPA in Australia. Instead, PLGF is only 40% detection rate for preterm preeclampsia. Very different than in the UK, that's 7%. If I'm adding PLGF in the Australian population, I can increase the detection rate for 71%. Just bear in mind that this population had intervention. The high-risk group, low-dose aspirin was prescribed. It means that there is an aspirin effect here. If you're correcting for aspirin effect, the detection rate 7-8% with 10% false positive rates. It means that PLGF is very important. If I don't have it, it's okay, but we really have to make an effort to have PLGF because the detection rate really improves in our population. Using another population as an example, this is the Danish population. Also, they showed a major increase in the detection rates if I'm studying using PAPA. If I'm using PLGF, I can increase the detection rate for preterm preeclampsia in the Danish population 15%. Now is the big question. Okay, this is a little bit complicated, but it's not that complicated, right? I just need maternal history, mean arterial blood pressure, uterine artery Doppler, and preferable PLGF. However, let's say that I'm working in the regional or rural Australia. I'm Brazilian, you can hear my accent. I did a study in a very nice but poor region of Brazil a few years ago. This part is called state of Ceará in the northeast Brazil. Very low socioeconomics. I don't have uterine artery Doppler. It's impossible to have PAPA or PLGF there. But using the Fetal Medicine Foundation algorithm for this population, if I'm using only maternal history, the detection rate for preterm preeclampsia was 43%. If I'm using only mean arterial blood pressure, was also 43%. But if I'm combining both, that's very simple. The detection rates went to 67%. That's far superior than maternal history. It means that even in regional and rural Australia, not having first trimester uterine artery Doppler, not having PLGF, in a very simple way, I can do effective first trimester screening for preterm preeclampsia. And then when I move it to Queensland, in one meeting, I showed to my hospital CEO the evidence, and he authorized the implementation of the third public hospital program in March 2022. And you are running this for over 3 years now, really improving our outcomes. We barely can see preterm preeclampsia in my hospital. My very few cases of preterm preeclampsia, they're coming from northern New South Wales and in a population that didn't have this screening. We can basically nearly eliminate preterm preeclampsia doing so. What we are going to do now for national implementation. In September last year, we got a major NHMRC partnership grant, and we are going to introduce this screening at 12 weeks at the same time than the Down syndrome screening, as I showed you. But also we are going to validate the Fetal Medicine Foundation 36-week screening for term preeclampsia in 8 major maternities across the country, with a total of 45,000 deliveries per year. This is supported by the Stillbirth CRE. The Stillbirth CRE that I'm part of this team committee has all the consciousness that doing screening based on maternal history, we're increasing quite a lot the number of unnecessary group scans that you are requesting for our women. And this is the reason that the Stillbirth CRE is really supporting and helping with these projects, that in the future we can have a better screening, not just for preterm preeclampsia, but also for term preeclampsia implemented in Australia. And another partnership that we made was with the Perth, Western Australia-based Australia Preterm Birth Prevention Alliance. You know that's a national program to decrease the rate of preterm birth, checking cervical length and prescribing prescribing vaginal progesterone for the high-risk population. However, if I'm doing first trimester screening for preterm preeclampsia, as I showed you before, we also can reduce preterm birth. And then Daniel Ronnick and myself, we are advising the group to introduce this screening in 9 centers in Australia, Metropolitan, Northern Hospital, with Lisa Rui and Kiri. You'll be one of the centers, but also in regional and remote Australia. We are checking the barriers and enablers for this screening, and then you are going back to federal governments with the intention for implementation, for whole implementation in our country. Concluding my presentation, I think that you can see very easily that maternal history by itself is not good enough to predict preterm preeclampsia. If I'm using combined screening, that's not very difficult to be implemented. I can individualize risk assessment, but even better, prescribing low-dose aspirin for this truly high-risk population starting before 16 weeks. I can reduce the rate of preeclampsia based on the aspirin trial in 60%, based on real-world work in Australia around 30%, but actually it depends of the intake of aspirin. We really can go to close to 6% that you can see in our hospitals nowadays. We also can reduce preterm birth before 37 weeks in around 80%, and reduce preterm birth related with preeclampsia and fetal growth restriction before 32 weeks in around 17%. Of course, like any screening program, is necessary investment. We need staff training and feedback. Implementation is not difficult, and this screening was quite well validated in Australia, as I demonstrated before. And this is the way for us to offer personalized care for our women, improving outcomes and decreasing unnecessary intervention. Thank you again. This is my Gold Coast team. I'm very lucky to live in this place, and this is my clinical team and my research team. I'm based here at the Gold Coast University Hospital, that's next door to Griffith University. And we're coming here for holidays. I'll be more than happy to have you for a visit and to show the way that you're doing routine first trimester preeclampsia screening completely free of charge for the Gold Coast women. Thanks so much.
Thank you, Professor Probiscio. That was very interesting, and hopefully in the next couple of years, we can build some guidelines for some of the collaborative hospitals to start referring and screening these women. Before we do questions, I'm going to change gears a little bit and introduce our final speaker. That's Dr. Tanya Alice to present on strengthening hospital responses to family violence.
Thank you, Richard, for the very nice introduction. I just wanted to clarify, I just noticed earlier I've been introduced as doctor. I'm actually a clinical social worker, but everything else is correct. Thank you, Richard.
Oh, okay. No worries. Thank you.
No problem.
Are you happy to do your slides or do you want me to pull them up?
I'm happy to do them. Yeah, no problem. I'll just do them right now.
No worries. Thanks, Tanya.
Thanks, Richard. Can everybody see those slides okay?
Yes, I can.
Perfect.
Thank you.
Okay. Thank you. So tonight I'm going to talk about family violence practice at Northern Health and how we have implemented the new legal reforms. I only have around 15 minutes, so we probably could talk about this all week. So obviously I need to be quite concise, but I do want to touch on the legal definition of family violence, the prevalence and the gendered nature of family violence. I will touch on the legal reforms and then I'll focus on our antenatal clinical responsibilities, which include mandatory family violence screening and dedicated consultation time. So this is the legal definition of family violence according to the Family Violence Protection Act. It's essentially any behaviour by a person towards a family member that's physically or sexually abusive, emotionally or psychologically abusive, financially abusive, any behaviour that's threatening, coercive or dominating, any behaviour that really causes one person to feel fear over another. And the legal definition is incredibly broad. It doesn't just mean male perpetrator, female victim. Anyone can be either a victim or a perpetrator of family violence, regardless of gender. And family violence includes intimate partner violence, violence by an ex-partner. Just because a relationship is ended never means the violence has actually ended. When a woman is planning to leave or after she's just left is an incredibly high risk time for family violence to occur, or for family violence homicide to occur as well after she's left. It also includes elder abuse, child abuse, abuse in same-sex relationships, and in some situations where a carer is looking after someone with a disability. So it's an incredibly broad definition. And at Northern Health, we see all of those types of family violence. The prevalence and the gendered nature. So although I said anyone can be a victim or a perpetrator of family violence, the data is very clear in that the majority of victims are women and children, with males being perpetrators. So this is the data here. This is what we know. 1 in 6 women and 1 in 16 men have experienced physical and or sexual violence by a current or previous partner. 1 in 4 women and 1 in 6 men have experienced emotional abuse by a current or previous partner. Notice how I'm saying current or previous. Many people think the relationship is ended. That means everybody's safe. Absolutely not. And like I said earlier, that's a really high risk time for violence to escalate and for family violence homicide to occur in the period where a woman's planning to leave or after she's just left. We know that 1 in 5 women and 1 in 20 men have been sexually assaulted and or threatened. And of course, all of this data is underreported. So many people will never tell anyone they're a victim of family violence. So obviously they're not sitting up here nicely on the screen. So if you think about the amount of patients you see every week, every month, every year, whether we know it or not, so many of those patients either are experiencing family violence or historically have experienced it. We know 8 women a day are hospitalised after being assaulted by their spouse or partner, and 1 in 12 women are hospitalised for partner violence when they are pregnant. I often wonder how many women need to seek medical care but aren't allowed to leave the home. We know it is the leading cause of homelessness. It's the greatest health risk factor for women aged between 25 and 44 years, and it costs us as a nation around $20 billion a year. Now, just very important to note that when these categories intersect with gender, the risk to a woman increases. And these categories are anyone who's Indigenous, young, pregnant, a woman who's separating, a woman with a disability, and any women in financial hardship. And of course, some women can be in all of those categories. That increases their vulnerability and the risk just continues to rise. So the legal reform, so we had major legal reforms introduced in Victoria a few years ago now. I just want to play this video. Just if you can't hear it or anything, just yell out. I just checked the sound before and then we'll regroup.
Family violence has devastating consequences for women, children, families, and communities. On average, 1 woman a week is murdered in Australia by her current or former intimate partner. 1 in 6 women have experienced physical and/or sexual violence by a cohabitating partner since the age of 15. Family violence is deeply gendered. The majority of perpetrators are men, and victim survivors are women and children. However, family violence occurs across all forms of family relationships and is not unique to any culture or specific community. That said, women who are marginalised and discriminated against because of their ethnicity, socioeconomic group, language, disability, sexuality, gender identity, religion, and age experience additional barriers to accessing services. Children are present in 1/3 of family violence incidents in Victoria. In a family violence context, there are likely to be a range of coexisting wellbeing and safety issues arising for a child. Children who have been directly or indirectly exposed to family violence often experience the long-term effects of trauma, which can be carried into adulthood, resulting in a range of emotional, mental, and behavioural problems. All parts of the service system have an important role in promoting the wellbeing and safety of children and identifying and responding to family violence. In recognition of this, Victoria has introduced new reforms. The Family Violence Risk Assessment and Risk Management Framework has been redeveloped and is now known as the Family Violence Multi-Agency Risk Assessment and Management Framework, or MARAM. MARAM now includes a wider range of evidence-informed risk factors for different population groups. MARAM supports organisations across the service system to better understand their responsibilities in identifying family violence and undertaking family violence risk assessment and management, including information sharing and cross-agency collaboration. For the first time, a range of organisations will be prescribed under regulations and required to align their policies, procedures, practice guidance and tools with MARAM. Government departments and peak bodies will be supporting organisations to understand what this means for them. Introduced in February 2018, the Family Violence Information Sharing Scheme permits prescribed organisations to share information relevant to assessing and managing family violence risk, including information about the perpetrator. The Child Information Sharing Scheme permits authorised services that support children, young people and families to share information about a child or any other relevant person in order to promote the wellbeing or safety of all Victorian children. Providing more collaborative and coordinated services to all Victorian children as early as possible is key to promoting child wellbeing and safety, preventing harm and avoiding crises. The 2 information sharing schemes complement information sharing under existing legislation and make it easier for authorised services to share information to keep people safe. All 3 reforms are integral to promoting the wellbeing and safety of children and reducing family violence in Victoria. This is a shared responsibility across our service system. Each sector is required to collaborate, trust, and reinforce the work of others to ensure that women, children, and families are safe and well and free from violence.
So most Victorian services are prescribed to the MARAM framework and the information sharing schemes, and these include police, child protection, specialist services, hospitals, sexual assault services, maternal child health nurses, schools, just about everybody. Now, GPs aren't prescribed to the MARAM framework, but of course they can implement the MARAM framework if they choose to, but they are prescribed to the information sharing schemes. So I just want to talk about what we've done at Northern Health. All public hospitals have had to implement the MARAM, and the majority of us have decided to do, a similar framework for our each individual health service. So the MARAM framework has 3 broad levels of practice. The first one is identification and screening, And that part of that very first level of MARAM is screening practice and sensitive practice. Screening, we've introduced in our antenatal clinic, and that means that we ask every single patient, so every single woman, the family violence identification questions, whether she looks like the healthiest, happiest person on earth or not. And we ask those questions 3 times throughout each pregnancy episode. Sensitive practice is the role of all of our other clinicians at Northern Health, so our medical staff, our nursing staff, and our allied health staff. Sensitive practice means that if a clinician received a disclosure or they suspected family violence was occurring because they're seeing family violence indicators or risk factors, that's when they would ask the family violence identification questions. So screening in the antenatal clinic, everybody gets asked, and everywhere else at Northern Health, we would ask the questions if we received disclosure or we suspected. The second level of MARAM practice is what we call intermediate practice, and that's the responsibility of all of our social workers at Northern Health. So they have the highest level of MARAM responsibility in our health service. And if a clinician makes a referral, then the social worker will go and literally do essentially all the heavy lifting. So the very in-depth risk assessment and safety planning, that's the role of the social worker. The third level of MARAM practice is called comprehensive practice, and that's only the role of police, child protection and specialist services. So in Victoria, they have the highest level of MARAM responsibility. But if I just take you back now to screening in the antenatal clinic, so we screen, like I said, every woman 3 times, and we do this at the booking appointment, the 22-week and the 32-week appointment. We can do this at any time. So if we receive disclosure outside of these appointments, and of course we would continue with the questions, or if we suspect it at a different appointment, then of course we would ask questions again. We have also introduced DCT, dedicated consultation time, because we have to ensure that screening is done safely and sensitively. So every patient will see the clinician for a brief period of time at the beginning of every single appointment. That's protected time where the clinician is to let any support people know that they're to wait in the waiting area. And then when it's okay to join, the clinician will go and ask the support person to join the appointment. I think our staff were a little bit reluctant to do this at first. There was a bit of resistance, if I'm being honest. But over time, this has actually worked really well, and all public hospitals are doing this now. So that first few minutes of every appointment, every woman is seen alone, and that's because if we don't introduce DCT, then we can't actually screen if support people are present. And we know some people have a support person there all the time, whether it's their partner or their mum or whoever it might be. So if we're not doing this protected time, then obviously we can't screen as well, or not as effectively. But these are the screening questions that we'll ask every single woman, and they're to be asked exactly how they're written during that protected time. But we would ask, question 1, has anyone in your family done something that made you or your children feel unsafe or afraid? Yes or no? 2, have they controlled your day-to-day activities or put you down? Yes or no? 3, have they threatened to hurt you or your children in any way? Yes or no? And 4, have they ever physically hurt you in any way? Yes or no? So they're very short, direct, quick questions. It doesn't take a long time. It literally can take, a couple of minutes. But at that screening and sensitive practice level of MARAM, that's what the research is telling us. To identify family violence, it needs to be quite clear, direct and quick. Now, if the patient answers no to all of these questions, we stop. That's all we have to do. If they say yes to one or more of those questions, that means we have received a disclosure of family violence. The clinician would stop again and offer a referral to social work. Most women, I would say, accept the referral and then social work come and literally do a very in-depth risk assessment and safety plan. However, if the patient has declined social work, so they're not interested in a social work referral, then we can also offer a referral to a specialist service, but some women don't want either. So then the clinician is required to ask 3 follow-up questions. And now we're really looking at identifying immediate danger. We know that approximately 1 woman a week is killed in the context of family violence. So if we're at this point, we really want to see, is this person even safe to go home today? And these are the 3 additional questions. 5, do you have any immediate concerns about the safety of your children or someone else in your family? Yes or no? 6, do you feel safe to leave here today? Yes or no? And 7, would you engage with a trusted person, professional or police if you felt unsafe or in danger? Now, all of our questions are in our EMR system, and it literally guides the clinician on exactly what they need to do next. But basically, if the person says no to 5, so no immediate concerns, and yes to 6, yes, I'm safe to go here today, family violence is still occurring, but there's no immediate danger. However, if the person says yes to 5, yes, I have immediate concerns, and a no to 6, no, I'm not safe to leave here today, this is when we've identified immediate danger and we might need to look at calling police, escalating to the team, consulting with social work. At times we've organised a social admission overnight for the patient to stay in so we can, have some more time. But that's when immediate danger has been identified, and that's when we obviously need to act quickly. Finally, referral pathways. At Northern Health, always social work is our go-to. We have 3 incredibly experienced antenatal clinic social workers who deal with family violence every week without exception. And of course, externally, police, if there's immediate danger, safe steps, they're a 24/7 crisis number. And they can literally talk to the person over the phone if need be at midnight or 3 o'clock in the morning to assess her level of risk, and if need be, they've sent taxis to the hospital and taken the person into secure accommodation because it's not safe enough for them to go home. The orange door is during business hours. 1-800-RESPECT is a really good number to give patients, 24/7 counselling number. So again, they can call from home if they need to at any time of the day or night. And then of course, child protection if there's any risk to children. But that's actually all from me.
Thank you for that, Tanya. That's
Thank
very
you.
helpful, especially that last slide.
Thank you.
Hopefully we won't need to use those numbers, but it's very useful to know. Before I throw it to Dr. Joanne for questions, I just want to answer a question that was sent to me. For Northern Health affiliates, Northern Health is accepting early referrals for screening of preeclampsia following Fabricio's guidelines. They will order the PLGF on behalf of the referrers. And we are going to be having a new midwife starting very soon to help us with our shared maternity care. So we'll keep you all up to date. I want to pass it on to Dr. Joanne Silva to go through with the formal questions. Thank you so much for the speakers so far. It's been really, really helpful.
Great. Thanks, Richard, and thanks for the speakers. They're fantastic presentations. So there's been a few questions. So Bethany, does the female length have a role in the diagnosis of small for gestational age, like patients with the fetus, normal abdominal circumference and head circumference, and a female length at 10th centile?
Yes, so thank you for that question. I saw that in the pop-up, and it's a really nice example of something you really commonly see on a scan. So in that specific situation, no, that would probably not represent a growth-restricted baby. What you're typically going to be seeing there is essentially, if you've taken a female length measurement like that versus if you've taken it like that, you're going to get a shorter female length or just a slightly short baby. The abdominal circumference is a really good representation of fetal nutrition. So it's quite a good measurement of that. And if the baby is not receiving good nutrition, it's going to get a shorter abdominal circumference. And all the bony measurements are fairly good measurements of the growth potential, which is why you'll often get a good head circumference or a normal head circumference and a reduced abdominal circumference. The female length is a bit more likely to be inaccurately measured, or it could be a short baby. If you do have an extremely short female length or an extremely short humeral length, then that could represent achondroplasia. So that is just something to consider. And if you do have a globally small baby, you will often have a small female length or humeral length as well. Was that an okay description, Fabrizio?
No, completely agree.
Thanks. You do more scanning than me, so.
No, yes, you're absolutely
You're making
right.
her anxious. And another question, sort of comment. Someone said, I've always struggled to understand, aren't 15% of all babies going to be under the 15th centile? Which percentage will be unwell?
Yeah, so sorry, that was a little bit earlier on in the chat, but maybe I should have come back around to that in my presentation. So it's about 50% of babies that are under the 10th centile that will be constitutionally small. But it can be something that's really hard to distinguish if they are a growth restricted baby or not. It's where we're really looking at babies that are crossing centiles, have a reduced centile, or have abnormal Doppler. Those are the ones that we know are unwell babies or are growth restricted. But yes, they're like by definition, 10% of babies will be less than the 10th centile, based on centile measurements that we have.
Thank you. Now, there's quite a few questions that have and comments that have popped up after Fabrizio's talk, because we're all, and I think it's come from us all switching from, not many of our patients having a first trimester combined screen, they're going for a NIPT. And so then it's like, well, what am I going to do? So, should we be ordering, given Richard's situation, but if you're somebody out in the sort of Western Health catchment or down to Werribee, should you be ordering a NIPT or a PLGF? What should we GPs be doing?
Actually combining both. I'm calling that NIPT plus, because NIPT, I think that is a very important point, never can substitute the first trimester ultrasound. This is malpractice if someone is having an IPT and not having a first trimester ultrasound. Unfortunately, I saw a couple of cases of anencephaly that someone had a low-risk NIPT. The GP didn't request first trimester screening. Patient came for a 20-week morphology scan. For this poor couple having this late diagnosis. And
sorry, Fabrizio, I think you're just freezing a bit. Maybe
the point of PLGF.
I was going to say, Fabrizio, you're freezing a bit, and it might help if you turned off your camera, and then unfortunately we won't see you, but we'll hear you.
Yeah, no, that's okay. Is better now?
Yes.
Yeah, what I was saying that first, the first trimester ultrasound is fundamental. We cannot substitute NIPT. We always have to have a first trimester scan as well. If I'm doing a first trimester scan, I have to collect bloods for NIPT at 11 weeks because PLGF is validated from 11 weeks. I think that's the only difficult regarding PLGF. If someone's having an NIPT at 10 weeks, PLGF has to be from 11 weeks. And I think it's so important to collect both. We're calling this NIPT plus, that you're collecting bloods at the same time for NIPT and PLGF. And then the women come to us at 13 weeks for the first trimester morphology scan. Why 13 weeks? Because it's the best combination in terms of gestational age to see fetal anatomy well. Nowadays, you can detect 60% of major malformations in the first trimester ultrasound. And then at 13 weeks, we do the scan, we calculate the risk, we are checking an IPT result, we are counseling this couple, and then they're coming back to you guys and to the obstetricians after that, fully counseled, if you are able to institute this kind of program.
All right, thank you. I think, for us, for some of us, I think it's going to be quite challenging to get those good quality nuchal scans because I think for some of our patients, we know that they'll, they might have a 20-week scan and they might go and have the nuchal scan, but maybe at Dodgy Dave's ultrasound service. And I think that's where we may not get such, those sort of...
Most ultrasound providers will still be able to give a really good early anatomy scan.
Yeah.
And it's just telling us really important things like, has a baby got arms? Has it got a head? Has it got legs? They can all do that, which is really helpful at that early point.
Okay, so we shouldn't be stressing about making sure they're COGU scanning
I
sites.
think that first trimester is really improving, Joe, and then we're having more centers, even the general radiology places doing more scans. They're going to get better and better. If you remember, when you started nuchal translucence, it was a paradigm shift as well, and we thought exactly the same. The providers are unable to do it, and then came the price and quality, and we end up with a very successful down screening program, right? I don't think that is any different in terms of preeclampsia screening and first trimester morphology scan. Of course, it's necessary training, education sessions like we're having today. Any major congress in ultrasound, obstetrics and gynecology, first trimester screening is a major component of that. It's very nice that UGPs are interested on that as well. Like anything new in medicine, we need a bit of education and training, but I think that you're having this.
Okay, great. Thank you. So I think that will alleviate some of our anxiety, because I think that was also an issue that came up last week. We were quite anxious about the quality of the scans. The algorithm that you showed, Fabrizio, is that available online for us all to access?
It is. It's completely free of charge. You go to fetalmedsfoundation.org. If you Google FMF UK, you'll be able to go to the website. And then on the left side of the web page, there are the calculators. You can use the online tool. It's completely free. And last June, the Fetal Meds Foundation also launched a free software that you can download the software in your computer and use the calculators.
Right, thank you. So we might share that in the resources for people, and we might then send some feedback to Health Pathways, Richard, and see if we can get it added to the antenatal pathways if it's not already there. So I've tried to group these questions. So this is another question comment. This may have already been answered, as I think you said universal screening is done in Queensland. However, for first trimester PET screening, do you recommend doing it for everyone who is willing and can afford it, or only low, moderate risk women who wouldn't otherwise be started on aspirin, given that a lot of our high-risk patients, for example, with diabetes or renal disease, would already be started on aspirin and have growth scans?
Yeah. Unfortunately, it's not whole Queensland that's having the first trimester screening at this point in time. It's only Gold Coast University Hospital. We have more centers that they are going to be part of the studies, and this will be one reason to try to increase implementation. We are working with Queensland Health, and we are trying to convince also federal government for more generalized implementation. But the concept of screening is to offer for everybody. It's not for a specific population. It's not for a low-risk group or a high-risk group, because actually you are doing a proper screening offering for everybody. It's like Down syndrome. We are not selecting a population to do screening. The whole rationale about screening is to offer for the whole population. As I mentioned during my presentation, history by itself is not good enough as a screening tool. The guidelines, there's a very interesting publication from a very leading group in preeclampsia at BJOG, and I was able to write a commentary piece together with Stefan Kane from Royal Women's about this publication. The guidelines that they put these risk factors that you mentioned, they are not based on evidence, and they are very poor predictors of preeclampsia. And this paper coming from Peter von Daldesen and Lauren McGee, that they are big researchers in preeclampsia. They really criticize the guidelines using maternal history. They are really not enough. We have to offer screening.
Okay. Thank you. Do you know what the cost of the PLGF test is?
Yes, is around, if you're going privately, is around $50. At Queensland Health, basically Queensland Pathology, the cost for the hospital is around $25, but for the patients, if the patient collects the blood at my hospital, it's free of charge.
Thank you. And just a couple of questions about aspirin. Is there a risk to starting aspirin prior to 10 to 12 weeks if the woman has significant history and risk factors prior to conducting the ultrasound?
Yeah, there's no benefits. There are a lot of studies coming from IVF wards of early start of aspirin, and it's not improving the outcomes. The ideal is to do the first trimester screening and then start at 12, 13 weeks, but we have to start before 16 weeks. There are strong studies and meta-analysis showing that if I'm starting aspirin after 16 weeks, it doesn't work.
Thank you.
And then we don't increase their risk of bleeding if they have a miscarriage in that early first trimester as well.
Yes, yeah.
And why would you recommend aspirin at nighttime?
It's a little bit odd recommendation. There's a couple of studies and they're checking the best time, and they showed that was at nighttime. I don't think that's a very strong evidence, to be honest. I think that's an easy time for the women to remember. And then compliance is the main factor, right? Because there are some randomized clinical trials that they prescribe a low dose aspirin for the whole population, and the compliance was extremely low, and the studies were negative. I think that if you are saying nighttime, the compliance helps with compliance as well.
Great, thank you. Does anybody know where which private pathology companies in Melbourne are doing the PLGF? Do you know, Beth? Well, everybody going to do the bleed and we'll send it off, I'm assuming, to a provider who does it?
All the companies that are doing free beta and PAPA, they are doing PLGF as well, because it's the same machine basically.
Okay, great, thank you.
Joe, I'm just going to interrupt and put up our evaluation slide and leave it there for the last 10 minutes. But I'll get you to keep going. So I'll just put that up.
Thanks, Richard. Just a couple more. Question here from Lisa Wee. Hi, Fabrizio. One of the comments from MSAC was that the FMF algorithm wasn't registered as a medical device. Is there something that needs to be addressed?
Comes the definition of what's medical device. When I was working with Thomas, and then we changed it for the Fetal Medicine Foundation, we did a consultation to TGA, because this is not a diagnostic tool. It's basically a risk calculator tool. It's not necessarily TGA approval. We are talking with RANSCOG at this point in time, and RANSCOG is going to do an official request for TGA to check if it's necessary to basically to put the Fetal Medicine Foundation calculator via TGA, and that the response will be no.
Okay, thank you. Yeah. Another question here, I've just lost it because it was for Tanya. How can patients obtain reliable and free financial and legal advice when they decide to leave their violent partners?
Oh, that's a really good question. I think if they're linked in with their family violence specialist service, they can work with them more longer term, and they will look at all of those issues, because we know when somebody's left a violent partner, there's many things to consider, but either the Orange or Safe Steps will work with them in a more longer term capacity than even we can at the hospital, and they'll look at accommodation, their finances? Do they need to have an intervention order? Does the children need to change schools? I kind of look at the situation holistically and help guide them, for quite some time, because it can really, it's quite a lengthy process after they've left the relationship, and then the healing comes later. So yeah, I would recommend a family violence specialist service who can often allocate a case manager to work with the woman in a longer term capacity.
Great. Thanks, Tanya. Another question going back to aspirin. I've heard a pharmacist asking a patient to throw out the other half of the 150 milligram aspirin. Is this correct, or can they keep to take the next day?
This is correct, and this is the TGA recommendation for any medicine in Australia. If you're cutting a tablet, you have to dispose the other half. It's not just for aspirin, but it's for any medication.
Right. Thank you. And another comment from Lisa. I think Lisa Richards already said that Northern's going to start looking to providing the PLGF as a pilot, which is fantastic, making us at Western look jealous. And another comment from somebody in the audience letting everybody know that Clinical Labs is offering PLGF. I think that is the end of the questions. I think I've tried to condense the questions that people asked about the PLGF and NIPT and things all into the one, because I think Fabrizio asked a lot of those through the session. So I hope I've got answers to everybody's questions. And I'll hand back over to you, Richard.
Thank you. So unless there's any other questions from the audience or the speakers, do you guys want to add anything else?
I just a final message, if I may. To implement anything new is a little bit difficult. It's a paradigm shift, requires a bit of efforts, but it's very, very possible. Denmark will be the first country to offer a national screening program. There are other countries that are quite advanced to do so. I think that in Australia, we have a good chance to be the pioneers in the APAC region to offer a national screening program for preeclampsia. And as you can see, really can improve the outcomes. And this is not very difficult to be implemented.
Yeah. Fabricio, we've got a question about the calculator. I don't have the website up at the moment, but where is the calculate button is the question. So I've sent the link to everyone and we'll include it in the notes after the meeting. But clicking through.
Yeah, what happens in June, they changed it for a new version online and also of the software. For the calculator button to appear, you have to put the gestational age. You have to the gestational age and all the information has to be there, and then the calculate button appears. This is a difference from the previous version of the online tool and the software, that you have to have all the information in place for the calculator button to appear.
That's an excellent question then, Ollie. Thank you for sending that through, because I think we would be scratching our heads. Thank you for clarifying that. Okay, or if there's nothing else to add, I want to give all of you a very, very warm thank you to giving up your Tuesday evening to come and present to us. We've had some wonderful speakers, and I think we've shared some really, really important knowledge. And so thank you everyone for coming, speakers and the audience. And we will be sending the slides and the recording in the next 2 weeks. Thanks, everyone. Have a good night.
Thank you.